श्री कृष्ण कहते हैं, समझदार व्यक्ति जब संबंध निभाना बंद कर देता है तो समझ लेना कि उसके आत्मसम्मान को कहीं ना कहीं ठेस अवश्य पहुंची है।
तुझे अपना बनाने की जिद भी तो मैंने ही की थी। तेरा जलील करना और कदर ना करना हक बनता है।
साला 2 दिन दारू ना पियो तो लीवर से खुद आवाज आती है, मालिक ओ मालिक, जिंदा है चली बसे हो। तेरी चाहत मेरी
मैंने कितनी बार देखा है जो हमारे साथ गलत करते हैं वो मौज करते हैं।
कितनू है
वो जो कर रहे हैं वो अपनी अय्याशी कर रहे हैं और आप अपने आप को पनिश कर रहे हैं उनके बारे में ये दिमाग में लेके।
अल्लाह क्या नहीं पूछा जाएगा ताजिया बनाया था कि नहीं, राजा साहब क्या कितने बार गए थे कभी नहीं पूछा जाएगा। पीर साहब का हाथ पैर छुपा था कि नहीं, एक मजार पे एक चादर चढ़ाया था या 1000 पूछा जाएगा। तो ये पूछा जाएगा तुमने नमाज पढ़ा था या नहीं। जो काम बिल्कुल जरूरी है उसे गैर जरूरी समझ लिया मुसलमानों ने, और जिस काम के बारे में कोई पूछताछ नहीं है उसको गलत समझ के ये कौम कर रही।
मुझे नहीं पता ये लाइंस किसने लिखी है, पर जिन्होंने भी ये इतनी खूबसूरत पंक्तियां लिखी हैं उन्हें दिल से मेरा धन्यवाद। ध्यान से सुनना। तू अपनी खूबियां ढूंढ, खामियां निकालने के लिए लोग हैं ना। अगर रखना है कदम तो आगे रख, पीछे खींचने के लिए लोग हैं ना। सपना देखना है तो ऊंचा देख, नीचा दिखाने के लिए लोग हैं ना। खिंच खिंच के निशाने हूँ मैं मारती, खुद ज्यादा तो उम्मीद मत रख सोने, ज्यादा तो उम्मीद मत।
ये दिल भी हुसैनी है, ये जान भी हुसैनी है, ये दिल भी हुसैनी है, ये जान भी हुसैनी। सच्चाई बोलने जा रहा हूँ मैं आप लोगों को। जो इंसान बहुत गुस्सा करता है, बहुत ज्यादा गुस्सा करता है, ये मैं नहीं बोलता, ये भागवत गीता बोलती है। जो गुस्सा करेगा ना और गुस्सा करता करता शांत हो जाएगा, ठीक है, अपनी बात रखने के लिए चिल्लाएगा, चीखेगा, इसका मतलब उसके अंदर तड़प बहुत भरी हुई है। और वो इंसान दिल का मासूम है, बहुत सच्चा है। वो हर किसी को खुश करने में लगा रहता है, हर किसी को। वो किसी की आत्मा को ठेस पहुंचाना नहीं चाहता, पहुंचाना नहीं चाहता। उसके बावजूद भी उस इंसान को सबसे ज्यादा सफाई देनी पड़ती है, सबसे ज्यादा उस इंसान को अपने आप को प्रूव करना पड़ता है। और कभी भी याद रखना, ऐसे इंसान कभी धोखा नहीं देते। अगर किसी की लाइफ में भी रहेंगे ना, पूरी ईमानदारी के साथ रहेंगे, पर इनका रिश्ता इनके स्वभाव की वजह से टूट जाता है, इनके गुस्से की वजह से टूट जाता है, और सामने वाला इन पर उल्टे सीधे तरीके के इल्जाम लगाता है, और ये घुटते रहते हैं। लास्ट में ये उस जगह से निकल जाते हैं, क्योंकि गुस्सा है तो प्यार है।
मुझे होटल में बहुत खराब लगता है कि बहुत लोग एक बोतल पानी खरीदते हैं और एक घूंट पीकर छोड़ देते हैं। शायद उनको पानी की अहमियत नहीं मालूम है कि आज भी दुनिया में ऐसे बहुत जगह हैं जहां एक बूंद पानी के लिए भी लोग तरसते हैं। हमारे एक बुजुर्ग ने बताया था, हजरत जैनुल आबदीन के बारे में। अगर मुझसे कुछ गलती होगी तो माफ करिएगा।
मैं बहुत कम लोग बचे थे करबला के बाद, जैनुल आबदीन उसमें से एक थे, और लगभग 20 साल वो रहे उसके बाद बहुत कम में। और जब भी उनके पास पानी का ग्लास लाया जाता था पीने के लिए तो उनके आंख से आंसू निकलते थे। 20 साल तक ये सिलसिला जारी रहा। जब भी वो पानी पीते थे जारी रहा। जब भी वो पानी पीते थे, जिंदगी के लिए पानी पीना तो जरूरी है। उन्हें याद आता था करबला का वो वाकया, जब एक एक बूंद के लिए, पानी के लिए लोग तड़प रहे थे। ये जज्बात है मुहर्रम का, ये जज्बात है करबला। ये चीज हम लोग को अपने अंदर रखना चाहिए। अरबीन
Right. Okay. Okay. Right. Okay.
हाँ अर्पित, हाँ चालू है मीटिंग, ठीक है चलेगा।
मेरा तो काम नहीं रहता है।
क्या बोल रहा हूँ?
मेरा उस काम तो नहीं रहता है ना।
काम तो नहीं रहता है, करना है तो कर सकते हैं ज्वाइंट, लेकिन तो
अच्छा।
काम तो नहीं रहता है।
ओके, वो तो आपको रिकॉर्डिंग करना पड़ेगा ना।
वो रिकॉर्डिंग तो क्लाउड के ऊपर चलते रहता है, क्लाउड पे।
अच्छा अच्छा अच्छा।
Hello, doctor.
Hi there, Sapnil. How are you?
I am good, sir. How are you?
Fine.
After long time, we
Yeah,
have
yeah,
met.
yeah.
Thank you, sir, for joining. I will request the team to follow. Though we had told all the doctors to join, hopefully they should join on time.
So,
Sir, basically, I hope Ritvik is there. Must have introduced himself, so he will also be there. And how do you
this is
want to do?
Ritvik only. This is Ritvik
Yeah,
only, the one who is there. Okay.
yeah, Ritvik.
Hi,
Okay.
good morning, sir.
Good
I'm
morning.
Dr. Ritvik, sir, working for Abbott Medical Team.
Yeah. I received your
Morning.
this thing. Yeah, just going
Yes,
through them.
yes,
Yeah.
yes.
Yeah. So, sir, initially, I'll just give a short corporate overview, and then I will introduce all, and then I will request you, and then I think from my side, should I share the slide or you? It's okay, right? Like if
You share the slide, no problem. You better share the
yeah.
slide.
And
So that,
after some time, I probably, I will just narrate the question because we just need to have a discussion, right? Like if in case there is a slide required in between, I'll keep it. And when the discussion is happening, I'll remove the slide so that we can see all of us.
yeah, sure.
Because there are only questions in the slide.
Yeah.
So primarily, we also want to take feedback on selenium sulfide plus salicylic acid. This shampoo we are launching in the coming month. So
Yeah.
just like
I was actually wondering why not why you didn't add zinc pyridine and selenium sulfide, because they are not compatible or what?
No, we had sir earlier Selsun Z, which was zinc pyrithione and selenium sulfide.
Yeah.
So that is also one option, and then this is the other option: selenium sulfide plus salicylic acid.
I think it should bring out both of them then in that case.
All three of them.
No, selenium sulfide as such, selenium sulfide with zinc pyrithione and pyrithione, and the other one is salicylic acid. So that will be, see, for some of the conditions like psoriasis, selenium sulfide plus salicylic acid definitely work.
Yeah, so that's what we are launching, that only. So selenium sulfide plus salicylic acid we are launching now.
Mhm.
And we also had launched earlier selenium sulfide plus zinc pyrithione. So that also probably we will relaunch again. So we want to take feedback, on how, when this molecule comes, where would they want to use
Yeah.
seborrheic dermatitis, scalp psoriasis, and all. So that all points we can discuss.
We have selenium sulfide as such separate without
Yes,
zinc
plain.
pyrithione.
Yes,
Plain.
yes.
That
So
is
plain
1%
we
or
have
2%. That is
uh,
1% or 2%, or both you have.
both we have. We have 2.5%, and that is the primary brand, and then we also have 1%, which is Selsun Daily, which
That is
is
your
our
that is over the counter. That is OTC.
that is OTC, that is yes, OTC product, or as in OTC, as in it is in cosmetic range.
Mm.
So that is primary. So there also, we want to understand like where we would want to put it.
Yeah.
Yeah,
Because,
Bhakti, you can talk.
here the problem comes when the doctors wants to prescribe. So they don't want to prescribe an OTC product, right? That is the reason why ketoconazole we were insisting. Nizoral, when shampoo came, we were insisting. If you
Yeah.
want Nizoral to keep it to as 1% in OTC, but 2% you give it to doctors, and don't put that 2% in OTC. That is what we were telling them actually long back. I'm talking about long back when ketoconazole was launched.
Yeah.
At that time they had two preparations, 1% and 2%. So 2%, I
Yes.
told them not to put in the OTC. If you want, you can put 1%. So the same thing you did for selenium sulfide, for Selsun.
No, no, sir. Actually, selenium sulfide OTC, as in I mean to say, see, whenever we get a product, there are two types of product. One is, a drug, or sort of a product, and second is a cosmetic product. So 1% is a cosmetic product,
Yeah.
and currently, but because we, as Abbott, we don't have expertise in OTC category at the moment. So our entire focus is only on doctors only with our product. So we don't have much of our product in OTC. Like we had earlier the Avin Ducre range in the OTC range because those were pure cosmetic. But those we stopped right now. So right now we don't focus much on OTC at the moment. And if in case parallelly, over the period there is a plan to have, but those will be with different brand names. Those will not be with this brand.
Okay.
I
How
think
many
Dr.
doctors have
Bharat.
joined? Dr. Bharat has joined.
Yeah, hello. Good morning, sir. Dr. Bharat and Dr. Surajit Gora is also joined.
Yeah. Good
Yes.
morning, Dr.
Good morning.
Surjit and Dr. Bharat, both of you. Good morning.
Good morning.
Bhakti, can you check with the rest of the doctors? Dr. Priya also has joined. Hello, Dr. Priya.
I think
Bhakti,
she's
can you
unmuted.
hear me?
Can you hear me?
Yeah.
Yeah.
Yes, yes, madam. We can hear
Hello,
you.
sir. Yeah.
Good morning, Dr. Priya.
Good morning,
Welcome.
sir.
Bhakti, I think you are on your. I can't see your mute. Also, I think you are having some issue in the network, so you can just log out and log in, re-log in. Ritvik, we had sent the slide which was given to you by Bhakti, right? Like the final one. That also we have sent, right? Hello, Dr. Deepa.
Hello. Just give me 2 minutes. I'll join back.
Yeah, sure, doctor. Can you hear me, Bhakti, now?
I can hear you.
We can't hear you, Dr. Bhakti. Dr. Manas has joined. Hello, Dr. Manas. Hello, Dr. Sumit.
Hello, good morning.
Good morning, doctor. Three more doctors to join the meeting. Isha, can you check with the team? Okay, I can't hear that.
Good morning, everybody. Dr. Lalwala
Good
over
morning,
here.
sir.
Good morning to everybody.
I'm audible?
Yes, sir. You are audible.
I think two more have to join.
Yeah. Just 2 minutes. We'll wait, sir. 2-3 minutes. Just checking with the team.
Swapnil, meanwhile, we can have the introduction of each doctor. That will be better. From which area they have come from.
Sure, doctor. So what we'll do is, by the time we start with the discussion, what we'll request each of the doctors is that, we give a short introduction. I will also be doing that however, since the meeting is not started as of yet, we can just do an informal one. So what I would request all the doctors is just to give a brief from where they are and how many I'll just just as area of expertise. I think Ritvik, we can start with the meeting for that per se. Okay. Yes. So we have today in total 10 doctors for this meeting, and it's an honor to have you all of you on this dais, and we have our esteemed Dr. Anjala Parthasarthi, who has been a part of many of our Abbott initiative, and has been very supportive for this meeting. And he thank you, sir, for agreeing to be the to be a moderator of this session. And Dr. Parthasarthi sir is from Hyderabad, and he has a vast experience in clinical and aesthetic dermatology. So I would request, just one line from each of the doctor, from where they are, and where are they practicing. So Dr. Bhavani Singh, thank you, sir, for joining this meeting. Just 1 second, hold on, sir. So we have Sir Dr. Surjit Gorai, who has joined us with us from Kolkata, and he is having 13 years plus experience in dermatology practice. Then, sir, we have Dr. Priya Talagiri. She is from Bangalore, and with a rich experience of more than 18 years in the practice. Then we have our very senior doctor. We are honored to have you, sir, Dr. Bharat Lalwala from Surat, who has more than 36 years of practice. Then we have Dr. Sumit Sethi from Delhi, with 14 years of more than 14 years of experience. Then we have Dr. Deepa Kanchan Koti with more than 2 decades of experience, and she is from Mumbai. And we have Dr. N. Shraddha, who is again from Chennai. Then Dr. Bhavani Singh with more than 2 decades of experience. Then we have Dr. Manas Sen from Kolkata, and Dr. Shivali Shetty. Dr. Manas Sen, again, a very senior dermatologist, sir, with more than 35 years in this practice, sir, and Dr. Shivali Shetty with more than a decade. So this is the entire group, sir, and I will request, Bhakti or Trisha, can you just follow up with the doctor, because since I can't hear Bhakti, her voice. So I think by that time, sir, if you're fine, I will start with the corporate one,
Yeah,
and
that will be
then they
better.
can
Yeah.
join in.
Yeah.
Okay, one. Okay. Ritvik, meanwhile, what you do is, you inform Bhakti or Trisha, because I can't hear Trisha also.
Sure,
I
sure,
don't
sir.
know what is the issue.
Sure,
And
Dr. Satya, I will follow.
just tell them which doctors are pending.
Yeah.
Yes,
And then
Dr.
we'll
Swapnil,
start
we
with it.
are in touch for that. We'll be back shortly.
Yeah, so we'll start with the corporate one, Trisha.
Yes, please.
Yeah. Okay. So thank you, because I couldn't hear your voice. So thank you, Trisha. So what we'll do is, we'll start with our corporate discussion and corporate briefing, and then I will go on to the main agenda. So I think there is some yeah. So, good morning once and for all, and thank you for joining with us for this advisory board meeting on dandruff and overarching dermatological conditions. And at Abbott, it's a privilege to have you all on dais and especially giving your time for Sunday morning for this scientific meeting. It's an honor for all of us. So, if I want to tell briefly about Abbott, Abbott is there in India for more than 100 years, and we have more than lakh of people working with us across the globe. And Abbott has acquired market leading positions in cardiology, diabetes, and derma per se in hair nutrition category over the past so many years. So hair care has been a very strong point for Abbott Dermatology. And beyond this, we have also worked in our gadgets and also devices, which have helped the doctor fraternity for years. We truly believe in science and science based innovations, and our science based innovation clearly come from the need which is there suggested by the doctors. This is one such meeting where we will try and understand the therapy, and also we will also understand we will also gain pointers on what we need to come up with in the coming future. So if we talk about today's agenda is dandruff being a very common condition. If we see the prevalence of dandruff is almost 50% in individual. So almost half of the people, every second person is at some point in his life has suffered from dandruff. And there are multiple conditions which are also associated with dandruff. If we see, this is a very slightly neglected topic, not many articles also are there. And so we thought that we come up with a consensus in this dandruff space. So the topic for today's discussion is dandruff and overarching dermatological conditions, because dandruff can occur in other overarching diseases also. So for this, we have Dr. Anjala Pathasarthi sir, who will be chairperson and moderator for this session. So before we start with the sessions, any initial words from your end, and then sir, we can start the discussion.
Good morning to all the doctors. Don't think I know everything about the skin diseases. You are the stalwarts. Most of you know better than me. This is only to reach a consensus statement among certain skin disorders. You know that facial as well as scalp and hair disorders are on the increase, and we are getting a lot of patients from that side, face, skin, face, scalp, and hair. And out of which the pityriasis disorders, right? Scaly disorders are also very common, especially dandruff, pityriasis, versicolor, seborrheic dermatitis, or psoriasis related to the acne. So pityriasis, eminentiaceas, so the hair loss associated with these conditions. So these are the common things which we commonly encounter. So we just wanted to reach a consensus statement. So what is the type of treatment we are giving? What is the etiopathogenesis? What is the seasonal variation among them? I mean, whether the children are affected, adults are affected more, or the gender variations. All these things we would like to know from you, from your expert panel. I am sure it will be a good educative program for all of us, including me. So let us start the program. We'll start with the slide presentation actually. I think Swapnil will be presenting the slides and I will be just going through the slides, and we'll be asking one by one. And let us be brief in our answers. Of course, if something is needed, clarity is needed, the other person can intervene. But usually we'll be asking every person. Suppose there is one question, so I have to take inputs from all of you. So all of you will be involved. So we'll go ahead with the slide presentation.
Thank you, sir. So right away, we will first go with the scalp related issues which are commonly seen in your practice. There are some listed here. What we want to understand from you is that based on your clinical practice, what are the common scalp related issues which you encounter in your practice. You can rate from this. If there is anything which is beyond this, you can also mention that in the slides. So over to you, Anjala sir.
Yeah. We know that these are the common conditions which we see: dandruff, seborrheic dermatitis, folliculitis, tinea versicolor, and scalp psoriasis. Among these, so which is the commonest disorder which you see in our practice? Dr. Surjit, because you see it most. Dr. Surjit, please. Or one of you, Bhavani, Dr. Bhavani Singh, and Dr. Bharat.
Good morning, sir.
Are you able to hear me? Are you able to hear me?
Yes, sir. Your
Yes,
voice
yes,
is loud
sir.
and clear.
Yeah, Bhavani Singh. Please, sir, Doctor sir.
Yeah, I feel the options mentioned are in hierarchical order according to their prevalence. Excepting tinea versicolor is something which I do not see very commonly on the scalp. Otherwise, pityriasis sicca followed by seborrheic dermatitis, folliculitis, and scalp psoriasis, and then possibly the last would be versicolor. And itchy scalp, trichodynia, or some other disorders we also commonly encounter in our practice.
Okay, trichodynia also is commonly encountered. Yeah, right. Dr. Smith.
I'll agree with this that the most common will be dandruff, followed by seborrheic dermatitis, then folliculitis, then scalp psoriasis, and followed by scalp eczema. I also don't see any tinea versicolor on the scalp.
No, this is not exactly meant for scalp. Generally, tinea versicolor on scalp is unusual, but this is generally on the body also. So if you give me a choice, dandruff I'll definitely put as a first choice, but tinea versicolor also will be there. If you are telling about not on the scalp, on the body, I mean to say.
Yes.
And seborrheic dermatitis, and then the folliculitis, and then the scalp psoriasis. Yeah. Dr. Priya?
Yes, sir. I do see the similar spectrum in my clinic also, but I would like to mention scalp folliculitis is what we see more often than the truncal or facial folliculitis these days, especially in males, middle-aged, younger males. Scalp folliculitis.
Did you say that is more prevalent than dandruff?
No, not more prevalent than dandruff, sir, but it is more prevalent than general folliculitis, is what I was about to highlight.
Yeah, you're right. Dr. Manas? Dr. Manas is there, please?
Yes, sir. We can hear you, sir.
Yeah.
In my list, I think in my practice, first I see dermatitis is in the top of the list, and then I will say the scalp psoriasis, pityriasis versicolor, and follicular. Actually, people will having, but they don't come only for the dandruff. That is the thing. That's why I'm saying in the top.
How about Sivani has joined? That's Sivani. That's Deepa. Deepa, you can comment. One by one, you can comment. Yeah, please.
Yeah, Dr. Shivali, she was trying to unmute. Yeah, madam. Then we'll go to Dr. Deepa.
Yeah, that's Deepa, please.
Yes, like 50 to 60%, sir, I have seen more of dandruff cases. Then, yes, of course, seborrheic dermatitis, and then scalp psoriasis and folliculitis. But yes, scalp psoriasis with the climatic changes, it varies, and folliculitis then do occur more.
Yeah.
Tinea versicolor more on the neck and the lower scalp occiput area, but not proper onto the full scalp.
Okay. Yeah,
Thank you, doctor.
With that, anybody I missed?
Sir, Dr. Deepa. Yeah.
Dr. Deepa,
Yeah,
I think.
What happens is when the patient comes, they are more in a panic state whether they have got scalp psoriasis because somebody, either a barber or somebody, has told them that this is psoriasis, and basically then they want to refute it, and that's why they come for that particular diagnosis. But in general, for a common dandruff, even if it is present, people generally come for seborrheic dermatitis in my practice more, and they ask for specifically consultation for scalp folliculitis. Then, of course, dandruff is there in most of the cases. So that even if it is number one, they don't particularly come for removing the dandruff. Seborrheic dermatitis because it causes scratchy, that's why they come, and folliculitis because it hurts. Tinea versicolor because they are afraid it is vitiligo, And scalp psoriasis, again, they find it as a dreaded
We'll
disease.
come to those points in the next slides. We'll come to those points. You are right, actually. I think everybody is done with all the doctors have given
Yeah,
entrance.
yeah,
Anybody?
Bharat sir, sir,
Yeah.
Dr. Bharat sir.
Yeah,
I
Dr. Bharat,
agree.
please.
I agree with the author. Dandruff is the first, seborrheic dermatitis and scalp psoriasis comes later on.
Okay, okay, sir.
You've
Yeah,
taken the points.
sir.
Taken all the points. Okay.
Yeah.
Yeah. Next slide, please.
Yeah. So thank you, doctor. So what we'll do is, we'll then start with our the next set of questions is primarily, we go to straight away to dandruff per se, because we all agreed, and saw that dandruff is the most common which is seen. So currently, what the aim of this question is that, see, dandruff is a very also a very self-treated disease. So we want to understand in the clinical practice, do you see patients with only dandruff in your practice, and what is the prevalence, usually age group, is it skewed to any gender, any patient profile? And also, since we have a panel across India, we also want to understand seasonal variation based on your geographical location. Is there any difference based on the region where you are practicing? Over to you, sir.
Yeah. Please, Dr. Surjit, then you please tell us the prevalence of seborrheic capitis or pityriasis capitis, whatever you call it as dandruff, the prevalence, the age, gender, patient profile, seasonal variation in just one, in a few sentences you can tell, so that I can ask the other doctors also. The prevalence of seborrheic capitis.
Yeah, Dr. Surajit, sir, can you? You're on mute, actually, sir.
Okay, he's on mute. Then we
I
can
think.
go. Yeah.
We can go to the next topic.
Priya,
Good morning,
Priya, can you
everyone.
tell us?
Good
Dr.
morning.
Priya?
Yes, sir.
To you
So
in this
dandruff is probably
holiday morning.
prevalent in up to 50% of probably Asian and non-Asian both population. Usually, just the pre-puberty or just after the pubertal spike is what we are seeing, that young teens and adolescents. And also, it continues to increase through the age of 18 to the younger adults. Probably compared to seborrheic dermatitis, 20 to 30 ranges commonly what we see for the general dandruff. And usually males are little more dominance in the males. We do see women with androgenic features like PCOS more often approaching us for the little tougher dandruff. And I throughout Bangalore, throughout the season is little cold and little less humid. So the dandruff prevalence is almost all throughout the year is what I have noticed.
Thank you, madam.
Sumit?
Yes.
Dr. Sumit?
I'll agree with Dr. Priya. Prevalence is very high, and post puberty we see a spurt of patients coming to us with dandruff problems. Seborrheic dermatitis in the higher age group and dandruff in the younger age group. And seborrheic dermatitis very commonly associated with androgenetic alopecia. And male patients are the ones that are coming more often. And yes, the prevalence increases in winters. More patients come to us with itchy scalp in the winters as compared to summers.
I think there are three age groups which are affected. One is the infants, which is less than 3 months of age. The other one is adolescent and the puberty age, and then the adults also. This is how we usually classify the age group distribution we usually do. So infants below the 3 months of age, cradle cap is the common thing which we see. And later on the puberty and adolescent, that there also we see the increase. And as Dr. Priya has told, it slowly decreases when compared to seborrheic dermatitis. This car usually it is seen up to 40 to 60 years also. After 60 years, we don't see dandruff that much. Yeah. Next, Dr. Surjit, he didn't come out, I think.
Yeah, sir. He was trying to
Hello,
say. Yes.
Dr. Shurjit
Hello.
here.
Yes, sir.
Good
morning,
Dr.
doctor.
Shurjit here. I'm really sorry because I probably missed a few of previous discussions, and probably
No, sir.
due to
Only
some
one
technical
question. We have only done with only one question. Yes, sir. Please go ahead.
Okay. So just tell me the question once, please. I have missed some.
Sir, the point is that in your practice, with regards to dandruff, Can you elaborate which is the common age group you see? Is there any gender skewness? And also, based on your geographical location, is there any seasonal variation? You see that where there is a spike of dandruff. Yes.
Got it. So regarding this age group, now if we consider dandruff, then it is the mildest form of seborrheic dermatitis without inflammation and localized to scalp, right? So this is a
Yes.
disease that is main complaint by almost all hair-related patients.
Yeah, that is true.
We see
The
that
age
and all those
group,
by
the
hospitalized or
prevalence.
YouTube videos. So that's why this is the commonest problem. But if you see logically, then only very few cases you get with proper inflammation. But nowadays, those patients who are having seborrheic dermatitis, if you do a trichoscopy, then you will find that many of the patients will have proper punctate dotted vessels. Those are fitting well into the criteria of psoriasis. So in my practice, if you see the pubertal age group or some sort of little bit more in females, especially the height is height of monsoon, height of winter. Those are the seasonal variations where I get most of the seborrheic dermatitis. But again, a part of it is gradually we can diagnose it as psoriasis, scalp psoriasis that was not been diagnosed previously without trichoscope. So that is my opinion in my current perspective of practice.
Yeah.
Right, sir.
Yeah. Dr. Manas.
Hello?
Yes, Manas, sir.
Is it
Anybody who wants, you just come forward, and then because everybody has their own turn, so please do come forward.
the dandruff? Then what I feel that so for only dandruff, because as Sojit Garai said, this is a milder form of seborrheic dermatitis. So for only dandruff, very few people comes first. But usually they come for the other reasons, other disease. They say that for the dandruff, all the pain probably in my practice, where I feel that 50% patients have the dandruff, mostly, and prevalence what in I in the dandruff. So I feel I seen that patient typically this is more during the winter season, and sex wise it's into more sexes. It's I found they're equal.
I think the audio is not that good.
So, sir, I could hear what sir said. So, sir basically mentioned pointers is that say, age, gender-wise, it's neutral, and he sees more of dandruff patients with regards to with regards to other types, and it's always associated with some other dermatological condition. Yes, sir. Dr. Bharat, sir,
To the
any
point
comment?
that everybody is agreeing to the point that the prevalence is more in monsoon and winter season. That is, everybody is saying the same thing. That is a point to be noted. Yeah.
Right, sir.
But I would say it is more common in men than in women. And
Yeah,
yes,
it is
of
the
course,
males are dominating.
it is
Seborrheic
more common.
dermatitis. Seborrheic dermatitis. Yeah, you are right, madam. Yeah.
Sir, now since we are there on this point of seborrheic dermatitis, and there is our next question was also under diagnosis. Usually, diagnosis is clinical only, or with patient, or it could be subjective also, based on patient's complaint. But just is there any challenge at time in diagnosis of dandruff, and are there, like how Dr. Surajit sir mentioned about trichoscopic findings of dandruff? Are there any different findings on trichoscope based on, like we discussed about scalp psoriasis, seborrheic dermatitis, or other types of scalp issues where dandruff is common? So what are the common trichoscopic pointers we should look out for? We can discuss here, sir. I think, sir, anybody who has experience in trichoscope can sir, elaborate little more on this, sir.
Anybody?
Yeah.
we want Surjit only to answer that question.
Yeah, Surjit sir, you can elaborate a little more because you are saying about trichoscope, right?
Okay. Yeah, yeah. Regarding the trichoscopic feature, while doing scalp trichoscopy, there are few tricks. Like if you try to do scalp trichoscopy, then first you have to scratch the lesion with a slide, so that we can see uh, we can remove the scalp. Then you can put some water, and then you can do a trichoscopy. So the polarized one will show regular pinpointed dotted vessels, and this is a diagnostic criteria for psoriasis. But if you say seborrheic dermatitis, then it will be irregular dotted vessels, mostly around the hair follicle. So that will more in favor of seborrheic dermatitis. So these two can be easily differentiated if you do a trichoscopy. And with more trichoscopy, that sebopsoriasis variant will come down. So previously we used to diagnose sebopsoriasis, and with trichoscopy you can classically stamp them as psoriasis. So these are the few pointers that we use in practice.
Not only that, the erythema component and scaling component. The scaling component will be much more in the psoriasis.
Much
The
more
erythema component
seborrhea,
also will
yeah.
be much more.
Yes, sir. Yes,
When compared to seborrheic capitis, because seborrheic capitis usually as you said, already pointed out, that is non-inflammatory when compared to seborrheic dermatitis. Seborrheic capitis is a little bit non-inflammatory, so the scales will be a little bit low, minimal and greasy and this thing. But in psoriasis, you get more scales and more erythema. That is always. And as you pointed out, the regular distribution of the vessels, that is very important in psoriasis. Irregular distribution in seborrheic capitis. So these are the dermoscopic features where you can differentiate between seborrheic capitis and psoriasis. But as you said, there is a condition called pseudophthoriasis also, where we just get confused. Either ultimately it may turn out to be psoriasis, most of the cases, or it may resolve to seborrheic capitis. So that is a term actually which has been coined long back, but I think it still has to be completely elucidated. It's not. It's only a stopgap term actually coined by many dermatologists, I think. Most of the cases we do biopsies. In case of psoriasis, in doubt is there, they're better to get a biopsy done, and then biopsy will claim the diagnosis.
Just a small point, sir. Like that I have mentioned regarding the scaling. Scaling actually doesn't differentiate that much. That's why I have told about the trick of doing trichoscopy. First, we have to scratch the lesion so that the scales get removed. Otherwise, the blood vessels appearance won't be that easy to appreciate. So that's why I think during trichoscopy, better to scratch the lesion and remove the scales and put some water so that it becomes blood vessels become visible. Otherwise, it is very difficult to clinically trichoscopically diagnose the seborrheic capitis and psoriasis.
Another thing is they are thick also, Dr. Surjit. They are thick and they're a little bit more erythematous. They are thick and they are well demarcated. And compared to seborrheic capitis, these psoriasis lesions will be well demarcated. Sometimes you do get diffuse scalp involvement. Their cases, as you said, you are right, but most of the cases will be having patchy distribution of scalp psoriasis, patchy scales. So the border will be delimited, very well demarcated in case of psoriasis. That is what we see.
Okay.
But anyway, you can go to the other question. If other people are agreeing with the same answers what you have given, we can go to other question, please.
Yeah. So we move ahead then to the next question. So now we have covered, on the dandruff part, on the diagnosis. Now, since we also wanted to target more on understanding on role of selenium sulfide in your practice for dandruff, so we go to the treatment. So what we can do is, their comment based on their clinical practice on role of selenium sulfide in dandruff management, and also other molecules if they are using in this treatment. So over to you, sir.
Deepa,
Yeah.
I think she didn't answer last. Deepa, maybe Dr. Deepa can give us the inputs regarding the treatment. Do you think that selenium sulfide you are using it, or what are the other things you are using? What is the duration if you at all use selenium sulfide?
Yeah, so I do give them selenium sulfide shampoo. Now we are staying in a city where, and in an era where everybody is affected more by the internet, and they, sometimes I see this attitude where they want to confirm with the doctor whether what they have seen on the YouTube is right, and they have their own biases of what works best for them, whether the YouTube works best for them or the doctor works best for them, because this is a condition which is long lasting. It is not that we have given the treatment and they'll never get the dandruff. So they do end up trying a lot of remedies before they come to us. And sometimes giving them the right approach, whether they will follow it or not, that is also a big challenge. So I try to give them in a stepwise manner. We tell them that dandruff is excessive oil produced by the scalp, and so you need to just simply wash your scalp on a regular basis with a good shampoo. So medicated shampoo like selenium sulfide 2 to 3 times in a week to begin with, later reducing it to just 2 times, and the rest of the days, if you have a lot of dandruff coming up, just simply wash it away. Only if it doesn't work, then we will go ahead with uh, additional medication for that, because sometimes there may be more of dandruff and less of seborrheic dermatitis, where you have very very few areas of pink discoloration in the scalp scattered here and there. So only on those areas if steroid application is done, because there can be a mix of this. There is no watershed line that this is dandruff and this is seborrheic. So there we can give additional this thing. And also dandruff, since it recurs in certain seasons or after exercise, so I do tell them to take head bath immediately after exercise and dry the hair properly. Some of the patients they use the wrong, I won't say wrong, but they would use practices which are, they will come and ask questions like, should I apply lemon juice, should I apply onion juice, should I apply bottle gourd juice or something like that. So I have to previously I used to defend telling how what is correct and not. So now I strictly tell them, go follow it. If it doesn't work, then follow what I have told. Don't argue and don't try to mix up everything. So then they try to follow that. And also, again, I tell them that avoidance of oil application will help, except for people who are like very great supporters of oil application, where they can't live without the oil application. Then I have to tell them, either you apply half an hour before your head bath, or I tell them that you try and avoid when the problem is really excessive, at least during that period, and then you may start only to the length of the hair. So these are some of the things that I tell only for dandruff, because seborrheic dermatitis will go a little step ahead, where we will require
We don't use any ketoconazole shampoos and all those things. Your choice is only selenium sulfide, madam.
so I do give, because it's a rotational therapy, in the sense, let's be practical, that even if we have given them one treatment, next time when they come with the same problem, if you repeat the same prescription, it's very difficult for them to satisfy their thing, that why did I even come to the doctor, if they are going to just do CT all. So what we do is do give them in rotation, and I do give them ketoconazole shampoo. I do give them zinc pyroxene shampoo, but there is always a level of this one is better, that one is better, something like
You
that. Or
feel
night
combination
application for
shampoos are
them.
better than single agent? Do you feel that any combination shampoos are better than single agent?
Yeah, combination shampoos are better. Sometimes I even give them because
Or
they
it
may
depends
not be
upon the
showing the
severity,
skin color.
or maybe you choose them depending on the
Depend,
severity of the seborrheic.
depending upon the severity. Depending upon the severity.
Dr. Sumit,
Sometimes I do
Dr.
give steroid shampoo also.
Dr. Sumit, please your inputs. Dr.
So
Sumit.
in case of plain dandruff or seborrheic dermatitis, I'll prefer selenium sulfide. Initially start with 2 to 3 applications per week. Then after that, I'll shift the patient after the dandruff is controlled. I'll shift to 1% selenium sulfide daily or alternative to be used in maintenance. But if a patient is coming with dandruff plus hair loss or endogenetic alopecia, then I'll prefer ketoconazole shampoos.
Dr. Shalini.
So I would say selenium sulfide is an anti-proliferative cytostatic, and yes, it should be used, and not only onto the scalp. If seborrheic dermatitis is coming onto the trunk area, it can be used over there for bathing purpose also. Onto the scalp, we should keep it for massage it and keep it for 5 minutes, and it does work well. Like first using it for twice or thrice in a week, and then tapering it off to once in a week. But not only that, the Indian people do still use coconut oil and other oils. We can direct them that they can use mustard oil with slight lemon and applying it half an hour prior. It also sometimes does take part in reducing the seborrheic dermatitis and dandruff. And other agents like zinc and lactoferrin and cyclopyroxamine and ketoconazole, that also works well. Combination with tar also, if applied just for nighttime application. If high seborrheic dermatitis, we do add steroids, topical steroids. And later on, if more of seborrhea is there, yellow crust, we have to add keratolytic. And yes, of course, the later end, we add oral antifungal as well.
Dr. Priya, you agree with her statement?
I do agree, sir, but I would like to add one point. I usually like the patient to wash their head as a first wash with a neutral shampoo, which can prepare their scalp to receive this antifungals well, and also the effect of these antifungal shampoos, whichever antimicrobial or anti-keratolytic or anti-proliferative shampoos, whichever we chose, it can last longer is what I believe. And combination and rotation and multiple agents started then tapered as giving long-lasting effect. When it comes to selenium sulfide, it is basically working as antimicrobial only, but have found even ketoconazole to be equally effective as an anti-seborrheic also.
Dr. Shraddha is there? Dr. Manas, I think Manas has given his inputs, I think. Manas?
Yeah. Am I audible?
Yeah, you are audible.
Okay. As you said, only regarding the dandruff, so I'll stick on dandruff.
Okay.
The dermatitis. As you asked that whether I use the selenium sulfide or not, yes, I do use the selenium sulfide. But if I see that having very, very mild dandruff, I only tell to use any normal shampoo, not to go for any selenium sulfide or any other shampoos. Normal shampoo will do. But if I see some moderate kind of dandruff, then I go for selenium sulfide twice a week initially for 3 to 4 once a week. And that time, sometimes I add an antifungal shampoo. So once a day, antifungal shampoo, once a week. Malaysia for his cause of the dandruff. The good thing that my speaker has told that she advised the patient with the normal shampoo before using the sulfide is very important, because most of the time what patients do, they use the selenium sulfide or shampoo, then they use the normal shampoo. That should be informed to the patient. They should not use the normal shampoo after using the medicated shampoo. They can use it for some other. That's important. Otherwise, that main problem.
It is Malassezia stricta and Malassezia globosa more than the Malassezia purpose, which causes seborrheic cavity.
Yeah. Not the Malaysia group. Malaysia group is.
As you said, mild, moderate, and severe psoriasis means severe seborrheic cavities. Depending upon the severity of the condition, we use different varieties and different combinations also. Anything from Dr. Surjit? Can you please give your inputs?
Yes, sir. Sir, all my panelists summed it up very well. Few points that I have found I can add is during analysis of seborrheic dermatitis, better to assess the systemic conditions also, like some immunosuppression, some sort of metabolic syndrome, mostly diabetic patients, dyslipidemia patients. Those patients are prone to have it. So that is another aspect to be kept in mind. Second, all the shampoos and therapies are well discussed already. But nowadays, like Dr. Deepa probably summed it up well, to manage the patient in practical sense is very difficult, because they will think about home remedies, or sometimes this kind of shampoo, if you write this one, they will tell this one. So you need to really individualize and be very specific for management of seborrheic dermatitis in every patient. We have a lot of options like ketoconazole, laliconazole shampoos, cyclopyrox shampoos, ZPTO, selenium sulfide. But nowadays I am trying to avoid the steroid lotions, because there is a abuse potential that might lead to folliculitis. So scalp folliculitis is probably, I have seen mostly due to steroid abuse. So that's why in those cases I try to give tacrolimus lotions or those kind of calcium inhibitor lotions. So that works well for me. And if I find it psoriasis, I think I treat it
Sir, we'll
on
discuss
that
scalp
manner.
psoriasis in the coming slides, sir.
So we treat it in that manner. So this is my take.
Yeah. Yeah, tell me.
Sir, if we are discussing only pityriasis sicca, then a
Ah.
gentle shampoo, a gentle mild cleanser will solve the purpose, and
Yeah.
maybe once a week antifungal is required. Too much of shampooing, too much of harsh shampoo use itself, in
Irritate the skin.
my
Once
opinion,
again,
irritates the skin and
disrupt the
causes more of
epidermal barrier function. You are right.
yes,
Epidermal
sir.
barrier function
And
disrupt.
I do avoid salicylic acid if the patient is already using. That aggravates the dry scaling. That I reserve for seborrheic dermatitis use than in seborrheic capitis or pityriasis sicca. I find use of salicylic acid aggravates dry scaling in case of normal dandruff or pityriasis sicca.
Maybe you can use it in scalp psoriasis.
Yes, sir. That
Not
is
in
reserved.
seborrheic capitis. That is what you mean to say,
Yes,
right? Okay. I think then you can go ahead with the other
Yeah.
questions. Other
Yes,
questions.
sir. So Dr. Bharat is yes, sir.
My choice is, as far as the dandruff and seborrheic dermatitis is concerned, selenium sulfide will be the first choice because it is having rapid and sustained effect, lasting for a long time. It is having anti-mitotic effect. It is having anti-proliferative effect. It is also having this malaise as a further effect. So as far as the patients of dandruff, seborrheic dermatitis, tinea versicolor are concerned, I put selenium sulfide as the first choice. And as somebody has told that normal shampoo is to be used first, and then comes the selenium sulfide or some other shampoos contain combination of the molecules.
Yeah. Yeah. That. Yeah. Please next. Go ahead with the other question.
Yes, sir. Yes, sir. So, thank you, doctor. Just, sir, one point, we also had some, data analysis where it was found that selenium sulfide is any in gender specificity is there, like you prefer more in men or women. Any comment is there? Just want to correlate it with the data. Any point, sir? We can just be very specific to doctors who are using this on day-to-day basis. So, Bharat sir, any gender specificities like that you prefer more in men or women with regards to selenium sulfide shampoo?
I think more preference should be given to male persons. Females are using these ornaments and gold ornaments or the necklace or something like that, or ear rings, etc. I think selenium sulfide is acting with this gold metal, so that thing is to be kept in mind. And I think selenium sulfide is somehow irritating and giving a late odor and something like that. So I think women are less preferring to selenium sulfide rather than other molecules.
There were studies actually, comparative studies between selenium sulfide shampoo, then ketoconazole, and then zinc pyridine with ketoconazole combinations. I think after all these things, selenium sulfide scored over the zinc pyridine plus ketoconazole and zinc pyridine as such as a shampoo. So there are studies actually. There are already studies there where it has scored because it has more of a cytostatic property. It is not a cytotoxic. It doesn't have a cytotoxic
Regarding
property.
gender,
And it has the
what is
anti-proliferative property of the Malassezia species also, plus keratolytic activity. So this is the reason why the selenium sulfide is pouring over the others. That is what the studies say. Yeah, apart from that, let us go to the other question because there are so many questions in
So,
the.
yeah, sir, we'll go to the next point now. Since we have covered now pityriasis sicca, some quick pointers on seborrheic dermatitis because there is a lot of overlap between these two diseases, and there is definitely there. So we just want to have a sir quick comment on how do they differentiate between dandruff and seborrheic dermatitis. Is there any difference in the prevalence, age group, and it's seborrheic dermatitis per se being a severe form of dandruff? How common age group, prevalence, and also we can quickly have on the management also. What is the choice of treatment in seborrheic dermatitis of the scalp? I think Dr. Deepa was trying to convey some point earlier. So, yes.
Deepa, you can put in, you can give your inputs.
Yeah. So in seborrheic dermatitis, the patient will primarily come with itchy scalp, and when you examine it, you will see the greasiness in the scalp, and the scales are thicker, oily hair, limp hair. That's what the patient describes, and you can actually see the pink color in the background. Depending upon how much is the area involved, you can see. Sometimes the patient is repeatedly asking you, "Is this seborrheic dermatitis? Is this not psoriasis?" So then you have to give them the pointers that yes, because there may be involvement of the eyebrows. You can see the eyelashes involvement, angle of nose, angle of the mouth, behind the ears, inside the ears, center of chest, and other area involvement. So you can explain them that this is seborrheic dermatitis only. And the advantage is that our treatment line then the is different from the one which we do. Prevalence wise, it is more in it depends, like if it is an exam season, people can get it during the stress period also. So it's not just the weather, it is the time of the year schedule which in which they are undergoing stress. Then I've seen a very high number in people who are having neurological disorders like Parkinson's or some psychiatric illnesses. They also have high prevalence of seborrheic dermatitis. These points I'm telling apart from what has already been discussed. And there are some people who are very stress prone, so they also have this. Now in patient profile, seborrheic dermatitis also is seen in people who have lot of acne, and mm, it's an extension that there is an excessive oil production and inflammation of the oil gland. But when I am treating the acne, I am very particular about using isotretinoin. And if the patient is having mood swing kind of a person, or where I feel that this person should not be put on isotretinoin, it is very challenging to treat seborrheic dermatitis in such patients without isotretinoin, oral isotretinoin. Apart from the steroids and the shampoos and avoidance of oil and keeping the scalp hygiene, all those things when they have been told.
The clinical correlation of dandruff and seborrheic dermatitis, actually dandruff is an extension of seborrheic dermatitis. Dandruff is a part of seborrheic dermatitis, that's what we can say. As you said rightly, the patient profile they're asking, what about the patient profile? The patient profile, how they present with seborrheic dermatitis. That is why I think you have mentioned about the areas which are involved. Yeah. Next, anybody who wants to put in their inputs?
I would like to add
HIV
would be
patients,
Yeah, tell me, Dr. Peter.
HIV
dandruff
patients are more prone to have seborrheic dermatitis.
Yes, sir. Sir, we'll just request Dr. Shelley to complete and then come to Bharat, sir. Yeah, over to you, madam.
So dandruff would be more like in adulthood, and seborrheic dermatitis is kind of biphasic in the infantile stage, like more of in the more than less than 3 months in adulthood, and also in senile age group. And dandruff is mainly restricted to the scalp area, and seborrheic dermatitis can be in the scalp, face, and onto the chest, trunk area as well. And dandruff will be more of a loose scales, and seborrheic dermatitis will be like slightly erythematous patches
More
and
inflammatory,
scaly
more
patches.
inflammatory. Yeah.
Yes, inflammatory patches. So
Yeah,
this
Bharat,
also.
sir.
Yeah, I would discriminate this dandruff and seborrheic dermatitis. Dandruff is considered to be a physiological thing. Seborrheic dermatitis is considered to be a pathological thing. Now, increase in melassesia furfur are the main cause regarding both the diseases, but the inflammatory part that is more important as far as seborrheic dermatitis is concerned. Immunocompromised patients, particularly HIV patients, they are having more growth of melassesia furfur and more thick scaly scales. Inflammation is more. So one should consider this part also while treating the cases of the seborrheic dermatitis. Some disruption of neurotransmitters, they are also related to these neuropsychiatric disorders. So that part is also to be considered as if we are treating seborrheic dermatitis as a whole.
Yeah, the other doctors pointed out mood disorders, and then Parkinsonism, the HIV patients, and then the dyskinesias, actually tardive dyskinesias. And some of the drugs also are known to cause seborrheic dermatitis. So androgen excess, sebaceous overactivity, all these things are definitely, they play a role in exacerbating or causing the seborrheic dermatitis. Of course, with the genetic tendency also. Yeah, Doctor. The doctors, please put in your.
Yeah. Any comments or beyond this?
From maybe Surjit. Where is Surjit? Dr. Surjit?
Yeah,
Yes,
Dr.
sir.
Surjit.
Yes, sir. Sir, I think this has been already discussed about the prevalence, age, and patient profile. It's quite similar for me, but as I have previously discussed the thing that metabolic syndrome or androgen excess, this kind of thing, PCOD patients, diabetic patients, or those patients with dyslipidemia, those are the more prone patient to develop seborrheic dermatitis. So that to be kept in mind and ask the patient to have a proper lifestyle and diet restriction. So those are also important along with medication.
Anybody wants to give in some input, please?
So I do not see dandruff and seborrheic dermatitis coexisting.
You don't see.
They don't appear coexisting.
Maybe
They do
one
not
of
coexist.
the
With
spectrum.
In some of the cases, they do coexist. No, Dr. Bhavani Singh. Yeah.
So that was my input. They give a past history of dandruff sometime in their life, but when they consult us, the seborrheic dermatitis is usually a bit recalcitrant or more severe. So I do not find them coexisting.
Yeah, I
I'm
support
answering
Dr.
to the question,
Bhabani
what is the
because
correlation between dandruff and seborrheic dermatitis?
yeah, I support Dr. Bhabani because what is dandruff? Dandruff basically a common layman's term. If I directly quote from Brooks, then it's a milder form of seborrheic dermatitis that is limited to scalp and without inflammation.
Yeah.
And this is
That is
also not a foolproof term that to be used in dermatology. So it's a common layman's term. So if I telling someone is having seborrheic dermatitis, then better not to use the term dandruff. So there is, I don't think, logical sense of coexisting of two diseases. The other coexistence of seborrheic dermatitis and psoriasis might be there, but coexistence of these two things, I think, bit confusing in logical sense.
What about others? Did you say that it is not an extension for this thing? I mean, of course, as Dr. Sujit has pointed out, group test was clearly described that is the extension of minor form of seborrheic dermatitis, the seborrheic capitis. That is what they say. But we have seen cases without seborrheic capitis, only seborrheic dermatitis happening. But we have seen seborrheic dermatitis patients having seborrheic capitis also. Those patients also have seen. It is individual variations, I think, but they are the same spectrum. They are the same spectrum. Is what I feel.
No doubt.
Yeah. Thank you, doctors, for this comment. So now, I'll not put up the slides. So just, quick comment on the management per se on seborrheic dermatitis. Your choice of topical in the role. So as an topical, what are the quick, therapy pointers? Anything new they also want to add? Any new molecule they have used and which they favor? Over to you, sir. Also, any biologics or any
But you have read
maths?
Asian guidelines also. So some of them you can answer those guidelines where the seborrheic dermatitis is being treated as per the Asian guidelines. Minor form, moderate to severe forms. When to use the steroids like that.
Right, sir.
Do you use oral medications? Of course, you talked about the topical. I mean, topical things ranging from selenium sulfide to ketoconazole to all imidazole group of derivatives and the cycloparaxolamine and all those things. Apart from that, maybe Poltar and all those things also can be used. But the role of the steroids and the role of oral agents, the role of topical steroids or topical steroid shampoos and the oral agents are also there in seborrheic dermatitis. So we just want to discuss about those things also.
Yeah. So oral, we can reach out to doctors. Dr. Priya, any comment from your end, like on oral medication? Yes.
Yes, sir. Oral ketoconazole, oral itraconazole is a preferred molecule only, but just the disadvantage would be giving it in long run, keeping in the mind that the hepatotoxicity or the the cytochrome 450 enzyme alterations and interaction with other drugs. So in long term, of course, to begin with the treatment for few weeks, oral itraconazole can be put in 200 mg OD or 100 mg PD dosage for few weeks. But I would like to add other deficiencies or anti-inflammatory agents as well. It has been found that pyridoxine, niacin, and all these vitamins are found to be little lower in patients suffering from seborrheic dermatitis. Even serum zinc levels are sometimes assessed. So these supplementation would help in long run. Also the diet modifications, probably somewhere the papers what we were reading were saying the whole fruit diet had a very less association with or improvement of seborrheic dermatitis compared to the Western diet. So we have to advise our patients or counsel them regarding that. And as far as the shampoos are concerned, again harsher shampoos which can again break down the scalp skin barrier or make that host immune response to a malassezia which the particular seborrhea patient is having. So the harder shampoos for long run wouldn't be that very suitable. We'll have to look for like a minor anti-inflammatory agents like climbazole or pyroptenolomine or the activated zinc pyrithione for longer run usage is what I feel, because most of the patients are already well informed. Qatar, salicylic acid, all these ingredients do work, but in long run they would again disrupt the scalp skin barrier. So we'll have to look for milder agents also is what I feel in seborrheic dermatitis. And lifestyle advice is also very important, especially when they suddenly come with late age onset, like middle age onset, especially in men, when they usually come in that 40 to 60s group, and probably they wouldn't have had the pubertal dandruff as such. What I feel.
Yeah, thank you, Dr. Priya. Dr. Sumit, any comment from your end on oral management?
I rarely use any oral therapy. In case the seborrheic dermatitis is very severe, I'll initially use a topical steroids to bring the inflammation down and then continue with shampoos only. As it is a chronic disorder, I don't see any point of using any oral therapy because the patient then sometimes they keep on using it on their own. So I usually try to control seborrheic dermatitis with topical therapies.
But one point to make, sir, whenever we give a short course of oral antifungal, they do have a very quick and very effective cure. Of course, it cannot be sustained for longer, but they do get a quick and effective cure. That is what I have observed.
There was a study actually on Asian guidelines. Actually, they have mentioned in severe cases of either seborrheic capitis or seborrheic dermatitis, the triconazole, then terbinafine, as well as the fluconazole can be used. That is what they have mentioned. In case of seborrheic dermatitis, maybe you can use it for 2 weeks, and then after that, maybe 2 days in a month for around 11 months to up to 1 year, you can use it. Is what they have mentioned. Terbinafine, if you want to use 250 milligram daily for 2 to 4 to 6 weeks, also up to 4 to 6 weeks, you can use. That is what they have mentioned. In severe cases, I'm not talking about mild cases or moderate cases. In severe cases, and even fluconazole also they have mentioned weekly once, at least for 4 to 6 weeks that they have mentioned. Similarly, so is the case with seborrheic capitis also. Severe seborrheic capitis, the role of itraconazole as well as the fluconazole and as well as the terbinafine, especially they have mentioned, but usually a limited period of time. Maybe they say 1 week, later on maybe intermittent therapy, because seborrheic dermatitis as well as seborrheic capitis, they tend to relapse. The relapse rate is very high among these people, so you have to have a maintenance therapy. That is what they have mentioned. But I don't know how many of you agree with this Asian guidelines which they have come recently in one of the journal. That journal is, I think, the Asian studies, the treatment of seborrheic dermatitis in Asia, a consensus guide. It has come from China, actually. So I don't know how many of you agree with that.
Right. Yeah, Dr. Deepa, any comment from your end with regards to what sir mentioned and also on oral therapy?
So
most of us won't give the oral therapies except in severe cases, severe or moderate to severe cases, I think. Mild cases, nobody will try to give oral therapies, oral medications.
yeah, so counseling plays an important role where the patient has been told that this is a recurrent condition and recurrent use of antifungals will not be advisable. If the condition is where the hair is very limp, I do, as I told previously also, I do prefer to use the isotretinoin as well, especially if it is in combination with acne also. Also, if the inflammation in seborrheic dermatitis has extended to other areas, which is very much frank, I prefer to use a short course of oral steroids. This will bring the condition immediately under control because that really controls the inflammation very well. And then we tell the patient to shift to the topical. And in the topical, I prefer to shift later from steroid to and antifungals to the topical tacrolimus or pimecrolimus in addition. It's, I have tried tofacitinib in severe cases of seborrheic dermatitis where there has been a something like scrotal skin seborrheic dermatitis or axillary seborrheic dermatitis which just refuses to go, and it does improve. But again, it all depends upon the patient's environment. So if the patient is in a very hot and humid area where it is recurring again and again, then it is difficult to sustain the patient for that long period on any drug for that matter orally. So repeated, I do get their tests done about
Yeah.
the enzyme levels.
As you said, I have tried in only one patient with recurrent seborrheic dermatitis. Every time he used to come to me, almost for the past 5 years, he's coming to me. I thought of even going for biological, but before that, I thought of putting him on cefacetam. Surprisingly, he's responding. And this is 3 months, third month, he's responding surprisingly. I'm not sure how it is working, but he's responding.
I especially put it for those cases of seborrheic dermatitis which are on other areas like the scrotal skin is the one which is more challenging.
Yeah, and so that we can go to other questions, please. Swapnil?
Sir, we are just on this biologics, which because madam just mentioned about tofacitinib. Just wanted to take a quick feedback from doctors. Any other biologics they're using in seborrheic dermatitis? Any comment which, because this can be a potential new product for us also. Just wanted to have an
Give you
understanding.
a little bit of cytokine profile in seborrheic dermatitis. Cytokine profile in seborrheic dermatitis will be IL-2, IL-8, IL-6, and TNF-alpha. They are increased in seborrheic dermatitis. So naturally, when the TNF-alpha is increased, naturally, the TNF-alpha inhibitors may play a role. But there are cases where after biological given, it's not the TNF-alpha inhibitors, especially the IL-17 inhibitors they are given. We have seen a few cases of seborrheic dermatitis developing on the face. We have seen. It exactly looks like a dry, scaly skin, but more on the nasal level area and the eyebrows and the eyelashes. These kinds of cases we have seen with IL-17 inhibitors, not with TNF-alpha inhibitors.
Right, sir. What about JAK inhibitors, like the ones which are now tofacitinib, and there are many which will be coming. Any comment here, because there's a lot of literature now on this, and especially in psoriasis, these molecules are targeted over the period. So any comments are on JAK inhibitors?
Most of the doctors are using. I think you can give your inputs. Most of the doctors. Yeah, one by one, you can tell us your experience with JAK inhibitors in certain conditions.
Yeah, any comment? Yeah, madam, please go ahead.
I use a lot of tofacitinib, but I'm very particular about getting the investigations done. I have seen a lot of patients who come from other places who have used this drug, but there has been no investigation done. And I had once attended a conference on psoriasis and tofacitinib, where some rheumatologist had commented that this drug, once launched in India, will be sold like chocolates, and then there will be a lot of side effects that will have to be tackled. Initial in the time that it has been launched, I was not seeing any side effects, but of late I did see patients complaining of stiffness of the neck or lowering of the I won't say lowering of immunity because there's no measure of that, but developing sore throat. So we know what we're looking at, and certain changes in them, then yes, you have to stop. Plus, there is a rebound which is very bad with tofacitinib. So tapering of the dose and prolonged therapy, and making the patient understand that the effect is not that if once it is achieved that you will not get the problem back again. Re-monitoring, re-investigations done. All this is important. Thankfully, some of the companies are doing all the investigations on behalf of the patient because the patient will be crushed for with the cost of the investigation only. So I prefer to choose only those brands, I would say, which where the patient has been given at least a free testing. We know that we are not going to go wrong at least with starting the therapy. Rest they then have the choice of buying any brand, because we can't stop them from buying any brands, because there are cheaper brands which are available. But monitoring is very important with tofacitinib, even if it is a wonderful drug.
The main problem is how long you have to give and when to stop, and then what about the relapse rate? This is the major problem we are facing with tofacitinib, even other diseases. So,
Right, sir.
anybody, please
Yeah.
give their inputs.
Any other comment, or then we can move, sir, next to next.
Chances of infection with tofacitinib are quite more. Patient may not come to you, but they will go to some physicians and surgeons just for some renal problem, and they will go for surgery. And after that, you will be informed that with tofacitinib, the thing has happened. So we have to keep this thing in mind. Monitoring is quite important. Regular routine checkup is also quite important for when you use this tofacitinib.
You can go to the other slides, please.
So yes, sir. So the next point of discussion is, tinea versicolor per se, which we discussed earlier, like primarily at the lower part of the scalp, very common. But just quickly wanted to understand any point which they want to highlight on the prevalence. And second is on the treatment. What is the choice of topical management in your practice? Just 2 comments we can take from all the panelists.
Dr. Bhavani.
Is a topical regarding topical drugs in
Yes.
pityriasis versicolor? I prefer a ketoconazole shampoo and oxyconazole lotions or ketoconazole stay-on preparations as far as topicals are concerned.
Thank you, sir. Dr. Sumit?
I usually use a combination of oral and topical. Orally, I'll prefer fluconazole as a single start dose of 400 or 300 mg per week for 4 weeks, combined with topical selenium sulfide shampoos for 30 days, to be kept on the skin for 5 to 10 minutes while bathing.
That is good, actually. Most of the times we do selenium sulfide application for at least 5 to 10 minutes, and then I tell him to take bath. That will be always useful, apart from the topical imidazole lotions and all those things. Yeah. Inputs from others.
Yeah, Dr. Manas, sir, any comment?
I use same that like oral and topical. Oral, I prefer the fluconazole, and particularly for the recurrent cases, I use the selenium sulfide. Say,
you give these itraconazole, these things for 2 weeks or 1 week, or you just go on giving an intermittent therapy? What is the dose you give, Dr. Manas?
Which one? Selenium sulfide?
Not selenium. Selenium sulfide application, no problem. I'm talking about oral.
Oral, I give that 400 stat, and then after 2 weeks 400. Fluconazole. Yeah.
For how long?
That two days only. 400.
2 to 4 weeks. Okay. And suppose you are giving itraconazole continuously, you give it, or intermittently you give it?
Some cases with this extensive tinea versicolor, I go for the itraconazole for 7 to 10 days. 100 milligram BD.
Yeah, that's 1 to 2 weeks, they say. How many people are using them?
Yeah, Bharat sir, any comment on oral? What antifungal you are using, and topical, sir? What is your choice?
We can use itraconazole as well as this ketoconazole also, just for 10 or 15 days, not more than that. And topical treatment is the best reference to me, rather than oral one.
Dr. Surjit, we are not hearing anything from Surjit of late. Where is Surjit?
Yes, sir. Yes, sir. For tinea versicolor, I currently use itraconazole. That is most convenient to use, and it is usually for 2 weeks. And I ask the patient to continue the topical therapies for a long time. Like what I say is oxyconazole or some kind of antifungal just after bathing, as oil applications all over the body for quite long time, if it is widely distributed in the body. So that is my strategy in managing
If you use selenium sulfide, you use it twice a week as a topical shampoo product?
Not really, sir.
Yeah, any inputs from others?
Yeah, any Dr.
Topical
Shivani, any comment?
selenium sulfide shampoo application twice a week, will it help or not?
Sir, I think it will help if the lesions are very hyperkeratotic. Otherwise, the simple clotrimazole shampoos also work in moderate tinea versicolor cases. If they're very hyperkeratotic lesions, or wherein we get a little confused with that confluent reticulate papillomatosis kind of appearance in the neck, those areas will somewhere have to think, because this selenium sulfide is little, and there can be a little smell and discoloration involved. Otherwise, they can safely use it 3 times a week is what I have seen in my practice.
When you are telling that first you give normal shampoo and then the selenium sulfate shampoo, actually we do the opposite way. Selenium sulfate shampoo we give first and then the other shampoo we give so that the smell will be lost. That is what we used to do.
It is applied on the, I was referring to the body lesions.
Is 1% selenium sulfide available?
Yes, available, sir. 1%.
It is available in 1% as well as 2.5% also. 2.5% also. And it is available with salicylic acid also. That is what I learned. Selenium sulfate with 3% salicylic acid also is available as shampoo base.
Sir, we are launching that in coming time. So when that, would you prefer that shampoo in seborrheic dermatitis, like 1% salicylic, 3% salicylic and 1% selenium sulfide?
Psoriasis, scalp psoriasis definitely it will be useful. Yeah, when compared to seborrheic cavities, I think the concentration of salicylic acid should be a little bit less. So that it should not damage the epidermal barrier function.
Palmoplantar keratoderma will also respond to this more percentage of selenium.
Yeah, there are people. Yeah, you are absolutely right, Dr. Bharat. They have then palmoplantar keratodermas and those hyperkeratotic conditions where selenium sulfide as a shampoo applied for maybe 15 minutes to 2 hours also. It is giving rise to very good results. So because it is a keratolytic also. So that is a good input actually from one of the literature they have sent, the articles they have sent. I just was going through it. It is quite useful, I think. Either acquired palmoplantar keratoderma or the congenital palmoplantar keratodermas. I think it definitely be adjuvant. It will definitely an adjuvant to the existing condition.
I think this will be a new concept.
Yeah, I think that also can be used. I think once the selenium sulfate comes to the market with salicylic acid, I think definitely it will be used for those type of conditions where hyperkeratosis is more prominent. Yeah.
Right, sir. Sir, yeah.
Sulfide is already keratolytic. Should we add salicylic acid into it?
Yeah, and this is mild keratolytic, madam. It's actually more of a cytostatic nature and less of a keratolytic, and so that's why scalp psoriasis, I think we need more keratolytics.
Yes, madam, and it has
especially in pityriasis eminentia. There is a condition called pityriasis eminentia. I think everybody knows about it. It could be due to seborrheic cavities or atopic dermatitis or due to psoriasis where the hair shaft gets matted. There, I think I'm sure the selenium sulfate salicylic acid will definitely is going to work.
That's good.
Right, sir. So I think we have covered tinea versicolor part. Now, quickly, sir, before we move ahead, just wanted, because we were there on shampoos right now in discussion. If we see today, most of the shampoos, there is a lot of ask of paraben-free, sulfate-free, skin-friendly pH shampoos in the OTC category. Okay, but just want to understand at a doctor level, when you prescribe product, do you look out for these attributes, like the product should be paraben free, sulfate free, shampoo with conditioners, and also do you feel that skin friendly pH, or if these kind of attributes are there to a shampoo, do they really help you? Do you correlate it clinically, sir? Any comment from sir, from you?
Yeah, for telogen effluvium cases where people come with telogen effluvium with hair loss and all those, those cases definitely naturally sulfate free, paraben free, these things we usually recommend. But the other specific conditions, I think those type of shampoos may not be useful. We require a medicated shampoo.
Right. So as an added benefit to the medicated shampoo, like medicated drugs will be there, but these attributes are there, aesthetic attributes. So do you feel that there is a need of these at doctor level also with these shampoos?
I
Then the
think they are.
patient they ask for it.
The patient asks
It
for
would
that. Yeah, absolutely right.
it would help in ensuring
They
compliance.
absolutely ask for it. They will go there, they will call up, and initially, a few years back, we had this challenge because patient would go to the store and they would call from there, doctor, the shampoo that you prescribed, the face wash that you have given has got a paraben, and I don't want to use that. Now, because truly speaking, sometimes we don't know the fine ingredients whether it contains paraben or not. So some of the big brands which we have been writing for maybe more than 2 decades, and the patient just says that this particular brand contains paraben, so I don't want to use it, I want a sulfate free shampoo. Or for that matter, even if somebody is given a some sample and we give it to some relative or something like that, or some patient, and they say, doctor, that shampoo doesn't feel good, can you give me something better? So my always this thing is there that no matter as sir has pointed out, even if we use a medicated shampoo, we have to give a good OTC brand which gives the nice feel after the shampoo and more manageability, because the hair becomes too tangled, and the because of the basic pH, the manageability is a big issue.
They
They
need a
lose
conditioner also. They want a conditioner also along with the shampoo.
conditioner also, and conditioner causes a lot of hair loss once you start using conditioner. So how to counsel that patient? So invariably this is a challenge that medicated shampoo cannot be given for a longer period of time. So I restrict myself to using it twice a week, and the rest of the days I have to pick and choose a shampoo which has at least mentioned sulfate free, paraben free, or sometimes even I tell them that you go and choose any OTC brand that you like, because otherwise the condition doesn't go, and they either leave the doctor or they leave the medicine and they go back to what they were using. This is a big challenge, at least in metro this is a problem.
Right, madam. Yeah, Dr. Sumit, yes, trying to put point.
I think the future is cosmetically optimized medicated shampoos. They'll help us in ensuring compliance because mixing these medicated shampoos with OTC brands, if we advise the patient to do it twice daily and rest of the days a normal OTC brand, that decreases the efficacy of these medicated shampoos. Because the medicated shampoos, the way they work is they deposit the active ingredient on the scalp. So rest of the days when we are using normal shampoos, that ingredient is getting removed and the efficacy of the anti-dandruff shampoo decreases. So a better way be to use this cosmetically optimized shampoo that the patient likes, which leave the hair silky, detangled, and these which have all these mentioned things on them like paraben free, sulfate free, and pH optimized, so that the patient can use it freely or regularly without using any other shampoos in between. That will ensure more efficacy of the treatment that we have prescribed. I would not like it to be mixed with a OTC brand because that will decrease the efficacy.
No,
So maybe
any shampoo, as long as it doesn't break the epidermal barrier function, that will be advisable. Only thing is that shampoo should not break the epidermal barrier function, thereby causing more inflammation, more irritation, and all those things. Those we have to find out. Even regular shampoos also. I think probably what Swapnil means is pH. Maybe the pH of the shampoo. You mean to say that the pH of the shampoo should be maintained in an acidic or alkaline form or neutral form. Because the people are asking for the pH of the shampoo also. Some people say that this is irritant to me, this is causing lot of itching to me, like that the people will say, especially the coal tar shampoos, especially for psoriasis, we use a lot of coal tar shampoos. Then people come back and tell me that this is irritating me. So do we need a neutral pH based shampoos also? The answer is yes or no.
coal tar is more photosensitizing also. So I'll avoid it in patients who are having hair loss. So because if we use a coal tar shampoo in people with hair loss, when they go out in the sunlight next day, they may complain of itching and irritation. So that might be the reason the coal tar is irritating. It's messy. The odor is very bad.
I think
So any shampoo that contains
I think
these active ingredients and it's very cosmetically elegant to use, that will be a preferred way to go forward. And we can ensure compliance with that the patient will keep on using it if it has all these mentioned findings.
Yeah.
For psoriasis,
I think
sir,
proper vehicle and base is selected. I think coal tar shampoo is considered to be the best one as far as the psoriatic part is concerned. So, clean friendly vehicle and base is to be promoted.
Yeah,
That irritative
I think most
odor,
of the
etc.,
doctors
is
use coal tar
to be
shampoos for
eliminated
case of
with
scalp
the
psoriasis.
proper
I'm sure that most of them use coal tar shampoos, coal tar based shampoos for scalp psoriasis, coal tar salicylic acid combination. Or sometimes you would use some steroid based shampoos also for a few days, not for a long time. Yeah. You can
Right,
go for
Dr.
that.
Priya. Yeah, Dr. Priya wanted to comment. Yeah.
Yeah, Dr. Priya, tell me.
I mean, some of the patients refuse to use coal tar for longer, or they are little not happy with it. So something like urea-based keratolytic shampoo, some of the imported brands did have that advantage. Patients were really liking the remission period. They were happy to maintain their hair and scalp with those urea-based shampoos, but we do not find many of them. Otherwise, many such availability of those ones. Now we have good urea lotions for body psoriasis. But whereas scalp psoriasis with some urea containing shampoos were pretty good for patients is what I have found.
Okay, so please note down this point. Note down this point. Urea based shampoos will be maybe.
Urea based are available in the market.
Yeah. I mean, if I'm allowed to take a name, that Sescavel urea shampoo was it was very helpful in psoriasis remission period, or like few days a week, the coal tar, and the other days the urea was doing good job for them, reducing the scaling and the component of scaling. But right now it is not so easily available. That is a disadvantage.
It is imported product.
Yes. I mean, I'm allowed to take names, so then Sescavel urea I was referring to.
Okay.
Sescavel urea
Yeah.
shampoo.
Right, doctor. So currently, there are definitely there are a lot of scalp moisturizer ingredients which are there in the shampoo. You can look out for, which are there in the shampoo, which can help you. Usually, they are there in shampoos which are two-in-one conditioners, like shampoo and conditioner put together. They will usually have some scalp moisturizing agents also. Parallelly, there are also now new products launched in the West, which are which like body moisturizer. There are scalp moisturizers also, which need to be applied like a mask, and then you need to wash it off. So it works like a leave-on conditioner sort of a product. So those are definitely there. However, in country like India, where there is high moisture, and these kind of product can aggravate certain situation. But yes, in dry weather condition, these can be there. So, sir, we have completed the dandruff and the scalp psoriasis part. Sir, just, on the hair cosmetics, because, and also on the hair loss, because we covered dandruff and hair loss earlier, very common. So, but, these days, definitely even men, patients or women, they come with certain dermatological conditions, and there they would also request a comment from your end on the hair cosmetics. For example, in men, they would ask for what is the gel styling, or what are the creams they need to apply. So do you feel that these creams that also aggravate the dandruff condition, and in this situation what do you suggest to them? What is the line of treatment? And also for the females, sir, or what is your recommendation for the hair cosmetics when when they come with the underlying dermatological conditions?
Yes, I pointed out earlier. Any gel-based procedures or this thing which damage the epidermal barrier function of the skin will definitely aggravate the existing skin condition. So, scalp condition. That one should be aware of that. Any procedures, any hair cosmetic procedures or any hair gels which damage the epidermal barrier function as such. Because most of the conditions are associated with the epidermal barrier function. Most of the dandruff, seborrheic arthritis or seborrheic dermatitis, and even including psoriasis also, they are associated with the epidermal barrier function defects. So when further we aggravate that condition, and then the disease will flare up.
Right. Yeah, Dr. Deepa, any comment from your end? This, yeah.
So usually these products which are for, as hair cosmetics, they are not with the pharmas usually. So they buy the OTC brand, and as is true for any general statement, if a particular patient is having a problem with that particular cosmetic product, be it a hair color or some styling product, if they are allergic to some preservative or some main ingredient, then we have to tell them to discontinue the use. But otherwise, per se, if a company comes up with any such product, more competitive charges rates, then we don't mind giving it, because patients do ask for it, especially with hair loss patients. When we give them either serum or the minoxidil, the first thing that they will say is that doctor, baal bahut kadak ho jate hain, I don't want to use it in the morning. So we do need something in the morning, so that we can apply that BD dose. Invariably, because they don't like to use it in the morning, we end up giving them only once a day, which is underdosing. This is one challenge which we face this almost on the daily basis. And in seborrheic dermatitis, if we have to tell the patient to stop using oil, people who are used to having set hair, they find it that my hair flies and can give me a solution which will help. Or there are patients who will come and say that we have frizzy hair, like my hair is very frizzy. So to have them nice and silky look with a where they don't want to undergo any procedure of straightening or smoothening product procedures, then they do ask for any product which will give them that smoothening. Now we don't have any such product available in our armamentarium, so we find it very challenging to answer this, how to reduce the frizziness. There's hardly any product which is available to reduce the frizziness. If whatever we tell them as a gel and all, it just works for few hours and then the hair becomes frizzy again. So if someone can work on that, that will be good.
Yeah, right, Dr. Deepa. Deepa will definitely take that point into consideration. And Dr. Yeah, Bhavani, sir, any you were
If
trying to say?
patient has persistent scalp issue or dermatitis issues and is in the habit of using hair cosmetics, then I prefer doing a patch test with the cosmetic series, and I try to rule out atopy in them. That is my input regarding this particular question. And regarding ma'am, one company has come up with a hair moisturizer recently, so we can look into it if our patients ask for it.
Even the leave-on conditioners are available in our pharmacy, so that also
Yeah.
helps in frizziness.
Yeah, but it is only for few hours. It doesn't give a very good effect. That's the problem. So they don't like it. They really come for a solution which we can't offer.
Keratin therapy and destroy the hair.
Right, right. So, now that we have covered most of the points, or just, few comments on the patients who undergo hair procedures at your clinic, like, for example, PRP or derma roller or any other, hair loss procedures. And these patients also, is there impact of this procedure on the dandruff? And also, what is the management you usually give in this patient, and when would you start the anti-dandruff therapy in these patients?
For any hair procedure, if the dandruff is there, first treat the dandruff, then go for the hair procedure. That is what we do most of the times. Along with dandruff, we don't use, or along with psoriasis, we just see that the condition comes down, and then later on we do that hair growth promoting factor procedures, whatever we do.
With mesotherapy, sir, I have not seen any increase in conditions like dandruff. We give that some light therapy advice, those laser combs at home, which helps in little improvement in the growth. That does decrease dandruff little, does control a bit.
Right, doctor. New point on laser thing. Yeah. Dr. Surjit, sir, any comment from your end?
Regarding hair procedures, you mean?
Yeah, yeah, yeah.
Hair procedures and the
So
seborrheic
if
capitis
active
patients also.
inflammation is there, like seborrheic dermatitis or psoriasis, as Sir has mentioned, we usually defer the procedure. We try to control it first, then we ask the patient to go for PRP or derma kind of thing. And after doing the procedure, usually I advise 48 hours to not to apply anything. Then we can go with usual shampoos and the medications that to be given for other health issues. So that's what I do in my practice.
But yes, after transplant, we do see dandruff seborrheic dermatitis also can appear if they don't take precautions after transplant.
Right, madam. So how do you manage, Dr. Shivali, on this post-transplant? Any comment?
Actually, not me, but the plastic surgeon does the transplant, and they usually call them after the transplant for the first head wash. So the doctor itself does the wash and advise them some anti-dandruff shampoo to be used, very gently applied, and not to remove those crusts forcefully, and to continue with some anti-dandruff shampoo.
Right. Thank you, madam, for that comment. Sir, we have covered most of the agenda pointers which we had decided. Any specific comment from the panelist we want they want to give on the points we discussed? Anything we missed out, Dr. Surjit sir? Any comment you wanted to give? Yeah, and Dr. Deepa wants to say something.
Yeah, so actually when the patients have done some treatments like in the salon, like hair straightening or rebonding or smoothing, whatever they do, after that the salon people, they sell them a shampoo that you have to use only this shampoo, and they are so loyal, and they are going to follow this, they are not going to budge from it. I am not going to change my shampoo because otherwise my product will not last, or and they pay a heavy price for that. So I think even you guys can come up with something so that we can tell them that this one is a cheaper version, you can still use that, it is still going to do that, because they just don't budge. Even if whatever we write, they still go back with their own shampoo. If they have a problem, it's difficult to manage because they are not ready to leave their stuff.
Madam, there are a set of people where they are addicted to those hair clinics.
They are loyal to these
Run
people.
by the other non-dermatologists. So they won't come back to us unless there is a problem from them. Most of the time they go on they stick on to them. That is what I observe. And they don't come to us
So
unless there is a problem.
so in the metro, especially, I am from Bombay, so we find it very challenging because every individual is going to some salon, and if the salon people has done some treatment, then they will stick to that shampoo. This is for the treated hair. So I have to literally convince that if the same shampoo company gives one single shampoo for centuries together, nobody will like to use it. So that is why they have to sell one anti-hair loss shampoo, which will supposedly stop the hair loss, one anti-color loss shampoo, which will stop the color loss, anti-frizz loss, like that. Then people will buy everything because they have now a lot of plethora available to choose from. If so, we don't have such plethora. We have only one, and nowadays there is one which is like sulfate free and paraben free, that's all. But nothing like which is appealing, like you like this and you want to keep using it. That type of shampoo is still not there in the pharma market. I mean, literally, saying it from my own household, nobody uses any shampoo that I get for the sample testing. They said
We
you
go
test and
scientifically, they go unscientifically. That's why they thrive more than the dermatologists.
no, but then scientifically we can have more appealing one. It's not necessary that we have to have that non-appealing look for that.
Right, madam. Point very well taken. So, as you rightly mentioned, the need, what we as a pharma, we need also to understand that we need to have more aesthetically appealing products, and also packaging is a very critical point in dermatology these days. So, which appeals to the patient. So, we'll definitely take into consideration. And as Abbott, we always keep working on our packaging and evolving with to have a better outlook. Yes. Any other comment, doctor, from any of the panelists?
I think the selenium sulfide, which is being revisited once again, is a good option. So let us see if you are coming with selenium sulfide along with salicylic acid or selenium sulfide as such with 2.5%. I think keep the 1% at the over-the-counter product, not in the, this thing. Otherwise, people get the patients will say that this is there on the OTC. They have to save the same OTC product. So see that the 2.5% is mainly meant for dermatologists.
Sure, sir. Point will take it, sir, definitely.
Medicated shampoo that we are discussing, salicylic acid and selenium combination. I think it's a good one. But while prescribing this medication shampoo, the most common problem already discussed is the frizziness or the dryness of the hair. So what I tell them is just clean your scalp with the shampoo and then wash your hair with whatever shampoo you are feeling good. So that gives bit of satisfaction to them.
That is
Person clean with salicylic acid and selenium based shampoos for the scalp only. Don't try to clean the hairs. So that will manage. That helps us to manage the patient satisfaction aspect.
Thank you, sir. It's a very important point because many times patients, this counseling is very extremely important because they would apply it on entire hair, and actually these are to be applied on the scalp.
Right.
Right. Right.
And thank you all the panelists. I think Swapnil has made my job easy. So everybody has given their inputs. Maybe sometimes we have missed one or two people where they may not have come. I mean, we didn't involve them much, but don't think otherwise because we are all a group. So we just wanted the inputs, the consensus statement, so that maybe later on they combine all these statements and then they make a consensus statement later on.
Yes, sir. Sir, first, I would like to thank you for helping us with this entire session, and always a stalwart. Dr. Anjala Partharthi has been a part of our publications also earlier for moderating this session. So we also have our medical director, Dr. Ashwini, with us from Abbott. Yeah, Dr. Ashwini, any few comments from your end?
So, huge thanks from the entire Abbott team, everyone, especially you, sir, Dr. Partharthi, sir, for moderating the entire session, and everyone. I think we all understand that dandruff, whether it's the specific subtypes, the way we understand, or also the patient perspective, which I think was very beautifully articulated. We understand that it's a complex subject, and the fact that it is really a topic that needs a lot of discussion and a lot of valuable insights that we have gained today, right from the possible aesthetic contributes or attributes which are very important for the product to the fact that certain subtypes of dandruff that really need to be treated differently, including say the salicylic acid combination, which really needs to be only used in certain subtypes. So it's really a lot of valuable insights. My sincere thanks to all of you for sharing your valuable time. It's a Sunday morning, but last 2 hours, almost 2 hours, have really been very, very fruitful. I also want to thank the Abbott team, so Dr. Swapnil and the entire team who's organized this. Thank you so much.
Thank you, Ananda. Thank you.
Thank you, doctors. Thank you to the Abbott team, Ritvik, Akshay, Trisha, Shailesh for the back-end support as well. And special thanks to Dr. Ritvik.
And also Kabir, because
Thank
she has
you
done
for
the
all
end-to-end thing.
literature you have sent me. That is a good thing. We just went through. And one more thing, I just was surprised the dandruff, how much it is commercially, it is important. It seems that in USA, just the OTC products which they purchase for the dandruff, they amount to $300 million a year. Only for treating dandruff, the OTC product they sell in America, they amount to $300 million a year. So you see how much commercial potential is there for dandruff treatments.
Yes, sir. Absolutely. If you see, dandruff is the most commonly self-treated. It is the most common disease which is self-treated across the world. So definitely there is a lot of potential, and there are so many SKUs which are there. And there in that quest, the right treatment from dermatologist is lost in between. So with this consensus, or with this scientific attempts, we try and put this out of the box topic into the box with right consensus point, and it will be very important. We'll come up with the minutes of meeting also to all the doctors for this.
Thank you.
Thank you so much.
Yeah, thank you so much.
Thank
Good
you.
afternoon. So
Thank you, sir.
followed by lunch, but I think we have to take our lunch at home.
Yeah.
Thank you.
Yes.
Thank you, sir.
Thank you.
Thank
Thank you,
Thank you,
sir.
everyone. Thank you.
Thank you. Thank you.
Thank you.
Thank you.
Thank you, everyone. I think we can log out, Dr. Swapnil, right?
हाँ बेटा
Sir, session is over, so you all can log
Yeah.
out now, right?
Okay.
Thank you, sir. Bhakti, can you ask the Sentiment team to close the session, please?
Okay, ठीक है.
Thank you.